So thank you so much for the introduction and thank you so much for having me here. Well, today I would like to present you our latest research on myocardial injury. As we heard today already multiple times, troponin assays have improved greatly over the last few years, and this is superb. Yet it raises a few challenges for clinicians. One of them I would like to illustrate for you. So if we have time and troponin, we can draw a line for the 99th percentile. And we would expect our average acute myocardial infarction to look something like this. However, in some instances, we have the case where troponin is above the 99th percentile, yet the requirements for an acute myocardial infarction have not been met. We call this, since the fourth universal definition of myocardial infarction, myocardial injury. And there have been previous studies looking at this. Yet, some of them had rather small sample sizes, others even combined type 2 MI and myocardial injury, and some might not have used the most appropriate reference group. So what you can find actually is that many have a follow-up time between anywhere from 1 to 5 years. However, every single one of the studies I could find assumed proportional hazards, implying that the hazard ratio for all subgroups do not change over time. So our aim was to describe the clinical characteristics, phenotypes, and outcomes of myocardial injury. Now, the PACE study has already been presented a couple of times today, but once again, since so many of you have contributed to it, we took patients that presented to the ED with chest pain and had blood samples drawn at 0, 1, 2, 3, and 6 hours, and we measured the troponin T levels, and then had 2 independent cardiologists having access to all clinical data, performing the adjudication process, and we obtained follow-up for 5 years. We then divided our patients into 5 groups. Patients that did not have an elevated troponin reading served as a reference group. Patients with myocardial infarction were subdivided into type 1, type 2, and STEMIs, leaving us with our 5th group with myocardial injury. Now, to assess the proportional hazard assumption, we calculated the Schoenfeld residuals, indicating a highly significant p-value, therefore the assumption was violated. So what we did is we relaxed the proportional hazard assumption using time-dependent coefficients. We opted for a flexible parametric survival model implemented by Royston and Palmer. And we adjusted it for age, gender, GFR, smoking, coronary artery disease, liver disease, and malignancy. Let's take a look at the baseline characteristics. So we started with our roughly 8,000 patients, and around 1,250 of them had myocardial injury. And these patients tended to be older and present later to the emergency department in relation to their chest pain onset, chest pain maximum. If we compare them to patients with myocardial infarction, we see that they have similar or even higher cardiovascular risk factor rates, and out of any, they show the highest rate of non-cardiovascular comorbidities such as malignancy, chronic kidney disease, liver and lung disease, and pulmonary embolism. Now, we went on and wanted to see what was commonly the most found trigger for an acute trigger for a myocardial injury. And we saw that the most common trigger was heart failure in females and males, yet it was more common in males. The second most common reason in men was myocarditis, whereas in women it was hypertension, and almost exclusively found in women was Takotsubo syndrome. So let's move on to the long-term outcome. And what I'm showing you here are time-varying hazard ratios for all-cause mortality. On the left, you see our subgroups combined. Keep in mind the reference line at 1 are our patients without elevated troponin. And on the right, you can see them individually. And what we can take away from this is that patients with myocardial injury initially show a lower hazard ratio in comparison to myocardial infarction. Yet, after 5 years, the hazard ratio for myocardial injury was at 1.9, meaning that someone with myocardial injury is 1.9 times likelier to die at 5 years compared to someone that did not have elevated troponin. This is very similar to type 1 MIN STEMI and higher than type 2 MIN STEMI and STEMI patients. A similar pattern emerges if we look at the time-varying hazard ratios for cardiovascular death. So here, once again, initially the myocardial injury patients have the lowest hazard ratio. Yet, after 5 years, it is very similar to type 1 MI and STEMI and higher than type 2 MI and STEMI patients. So this research is, of course, limited by the fact that it only applies to patients with chest pain that present to the ED, and it is not applicable to patients that are on dialysis. So to conclude, as described before, also in our cohort, myocardial injury patients were older. They had more non-cardiovascular comorbidities, and they had a similar or sometimes even higher rate of cardiovascular risk factors, maybe with the exception of active smoking. The phenotypes vary by gender, which is an important message to take from this. And for the long-term outcomes, the mortality, the all-cause mortality, is similar, if not even higher, than in myocardial infarction. And with that, I would like to open the discussion, and thank you so much for your attention.
Ryan?
Thank you very much for a very interesting talk. Two questions, very briefly. Why did you include EGFR rather than creatinine in your model when you'd already included age and sex?
So what we did is we created, what's it called? An acyclic graph that basically used the theory for this procedure, which indicated that the best, how should I say, adjustments would be GFR and not creatinine.
Okay. And then secondly, you looked at all-cause mortality. Now, obviously, as physicians, we want to try and reduce all-cause mortality, but there aren't a lot of medications or treatments that can do that. We usually try to target cardiovascular mortality. Do the same hazards apply for cardiovascular mortality?
So I'm not sure if I understood correctly, but so the hazard ratio is slightly different for cardiovascular mortality than for all-cause mortality. Unfortunately, due to the time restriction, I did not show you non-cardiovascular comorbidity, where you would have seen that it is slightly more similar to type 2 MIN STEMI instead of type 1 MIN STEMI.
Thank you.
I think he was first.
Michael, and then...
Hi, Carlos, thanks a lot. That was a really good talk, and I really liked how you put the phenotypes up, differentiating what a heterogeneous cohort this is. And I just wondered whether or not you had any outcomes based on the phenotype rather than the aggregation of all those patients with myocardial injury, and if there was any difference.
Myocardial injury, are they different mortality by
So we did not strictly look at this because of the sample size we had. So we thought about doing it, but it was not feasible.
Do we have time for one more?
Microphone is coming.
Yep.
Yes, thank you for a nice talk. You see this also in pulmonary embolism. When you have severe pulmonary embolism, you give them let's say you give them treatment, they die of other causes. So what's your message to us? What should we do with these people? These people die probably of other causes than cardiovascular causes. They are older, they got more cancers, they got more renal failures.
That is exactly the problem. So we know that they have a higher mortality and that we need to treat them differently, or that we at least need to treat them. So we need to figure out a guideline that would guide us and help us in figuring out whom to treat. We see that we have to treat them and how to treat them. And this is a very heterogeneous cohort, which creates a problem.
Okay, we're going to have to end the session, but thank you very much, Carlos, for a fabulous talk.